to UMR Connects. My name is Holly, and I'm a student here at the University of Minnesota Rochester. First off, I wanted to thank you all for coming tonight. This month, our theme is the amazing human brain. I will introduce tonight's speaker for this evening in just a moment. But first, I wanted to remind you I wanted to remind you that know and inform those of you that may not know that UMR Connects is every Tuesday night, and it's always right here in room 417 at 7 p.m. It's always free and open to the public. Spread the word. Bring your friends. We appreciate it. We choose a new theme each month. This month is, as mentioned, the amazing human brain. Next month, April, the theme will be the great unknowns. Lastly, if you haven't already done so, we do have a door prize drawing in the back. It's on that table when you first walk in, and if you want to put your name in the bucket, we draw for a $20 gift card at the end of the evening for the M-Gear store downstairs. You do have to be present to win. And without further ado, I'd like to introduce tonight's speaker. Emily Brunner, MD, grew up in Ridgefield, Connecticut, and attended college at Massachusetts Institute of Technology, where she received a Bachelor of Science in Neuroscience. Dr. Brunner then went on to medical school and residency in family medicine at the University of Michigan. After graduating residency, Dr. Brunner worked at Pain Recovery Solutions, a clinic specializing in pain and addiction, and Packard Health System, a primary clinic aimed at treating the underserved. During this time, she decided to obtain certification in addiction medicine. In December of 2014, Dr. Brunner joined the Hazelden Betty Ford Foundation, the nation's largest nonprofit treatment provider, to pursue a career in addiction medicine. Specific interests include treatment of opioid dependence and managing chronic pain in patients with comorbid addiction. Please join me in welcoming Dr. Emily Brunner.
Hi, I'm Dr. Brunner. Thanks everyone for being here and for your attention. I'm going to sit down because I'm about 36 weeks pregnant so that I don't have some sort of exciting fainting episode. But if you have questions throughout the presentation, you know the goal is to be a little bit interactive, so feel free to speak up if I ask for input. And raise your hand if you have an urgent question, and we'll try to make sure there's a little bit of time at the end for questions as well. So I'm kind of giving away my thesis in the front slide, but the main point of this is just, addiction is a disease of the brain, not a weakness of will, and there's a lot of scientific fact to back that up. In terms of financial disclaimers, I am employed by the Hazelden Betty Ford Foundation, but I do not do any consulting for pharmaceuticals or get any other compensation. So first step is just, reviewing what addiction means to you. So a lot of people have a lot of different feelings about addiction, and I think it's okay to acknowledge that we all come to this subject with our own thoughts and preconceived notions based on our own experience. So some people might relate to it being a lack of willpower, an amoral condition, an inability to handle one's liquor, or a brain disease. And I would submit that it is, in fact, scientifically a brain disease. And that's what this presentation will be about. Again, there's studies that only about 10 to 25% of what's presented in any lecture is retained, and usually that's within the first 10 to 15 minutes, so I really wanted to get a jump and just throw out my silver bullets that I hope you take away from this presentation, which is that absolutely addiction is a disease. There's lots and lots of evidence for that, and that it's not an incurable, hopeless disease, but one which has scientifically proven treatments. So first, again, just consider, your own, like a lot of people would come look at these two images and have maybe a certain bias about who is probably the alcoholic, even though the reality behind this situation is that the man giving the high 3 is a CEO of a Fortune 500 company who's going motorcycling about and just happened to be snapped in this position, and the woman is totally high on crack, and that's why she has such a big smile. So, just think about like whether you have overt biases that you might think of just seeing people and coming up with whether they might be addicts or not, and that's certainly not always reflected in reality. Recently there was a pretty comprehensive phone survey on what people feel about addiction based on about 800 adults who are sort of cold called. And just, I think it really underlines the incredible amount of people who are touched by the disease of addiction. So you can see 63% of people surveyed had some interaction with addicts somewhere in their life, so that's an incredibly high proportion. 2/3 of those people also felt like there was stigma towards people with addiction. 74% of people were ashamed to talk about that member of their family, and 27% actually admitted that they would probably be less likely to hire someone if they knew that they had that history in their past. But the majority of people did feel that discrimination against people with a history of addiction should end, so I would say that's very positive. Then, again, thinking about how you consider any disease, what do the medical experts say about addiction? And pretty uniformly, you cannot find a medical society that will submit that addiction is not a disease. The idea throughout every medical society is that addiction is a disease. Despite that, 60% of general practitioners actually feel that addiction and alcoholism is a moral issue. So that's an incredible dichotomy between, what is being defined by medical societies and what is being practiced by medical practitioners. So I think we've got like a long way to go there. And then, as a caveat, again, that is probably because we don't really learn a lot about addiction as a disease. So as you can see, most medical schools devote less than 1% of curriculum to a discussion of addiction. And the medical school I went to was wonderful. I had, 10 to 12 hours of lecture on a very obscure cause of hypertension called pheochromocytoma. And in my entire medical school career, we didn't have a single talk about alcoholism or addiction. So I just think that's really telling and interesting. And it's sort of borne out as objectively the way that medical school does treat this. So then just, again, to hammer home that, people with addiction are not always amoral or weak-willed. Does anyone know who these people are? Franklin, exactly, suffered with morphine addiction towards the end of his life, prescribed by his doctor, but probably did not lengthen his life. How about the other two? So the one with the gentleman with the glasses is Sigmund Freud, who had cocaine addiction. Actually, his first major paper was about how wonderful cocaine was, and he struggled with it sort of throughout his life. I'm sorry, they both have glasses, don't they? The one with the beard, I guess, is Sigmund Freud, and the one with the bushy mustache is William Halsted, who is the father of modern surgery and struggled throughout his life with opium addiction to the point where he would sometimes pass out in between patients. I believe he started using the opium as a treatment for cocaine addiction. And he sort of struggled with that throughout his life, but he was still, able to become the father of modern surgery. So imagine what he could have done if he had been properly treated for his addiction as well. Again, just to hammer home, as early as, the 1800s, Benjamin Rush, the father of modern psychiatry, promoted the idea that addiction and alcoholism was actually a disease. As of 1956, this was formally declared to be a disease by the society, the American Society of Medicine. And then in 2004, the WHO published a very clear report stating that addiction is as much a disorder of the brain as any other neurologic or psychiatric illness. So, that's not a subtle statement. And I would point out that it's it's really interesting that that was stated by the WHO 11 years ago, and 60% of general practitioners still don't feel that addiction is a disease. So there's, again, this sort of dichotomy between scientific knowledge and general practice sometimes. The definition per the ASAM website, I think maybe I'm hammering this point home a little bit too hard, but that addiction is a primary chronic disease of the brain, and then it has, features that reinforce that. So I just wanted to share a few cases that are absolutely true from clinical practice. Case one is PG, so a 32-year-old physician arrested for greater than 25 counts of prescription fraud and writing prescriptions for himself. He has been abusing more than 4 different prescription drugs and drinking cough syrup on a daily basis. He has also been using while working and has been to residential treatment more than 5 times without being able to stay sober. He continued to drink cough syrup, which is also called robo-tripping, throughout his treatment and was never sober. Got out, his wife found out that that was what was going on, took their 4 children and left him. He also then got arrested and had his medical license taken away. So do you think there's any hope for him to recover at this point? I see some nods. I like them. And then how about practice medicine? Would you want this man practicing medicine again? So, and I see a sort of couple mixed nods. So in this particular case, the outcome was that because of his fear of going to prison in Georgia, the patient fled the state and became scared and decided to pursue sobriety. He started attending AA, got a sponsor, and took a job chopping vegetables in the kitchen. After 3 years of continuous sobriety, he was given a chance to go back to residency and get back his medical license, and he did so. He also faced up to his out-of-state convictions and worked through the legal system. He went back to work for more than 10 years and became a leader in his field, treating hundreds of patients. He continued to attend AA regularly and was a pillar of his community until passing away from an unrelated issue years later. So, the next case would be a lawyer at a high-profile firm, drinking alcohol and snorting cocaine on a daily basis. This person didn't get into any work issues, but had a lot of personal problems from this, became isolated from the family. Her husband left her. She spent most nights drinking alone and watching TV. She started to develop right upper-sided pain in her abdomen and fatigue, therefore stopped exercising or doing anything else besides going to work. And this is sort of a classic feature of alcoholism or addiction, the ability to sort of preserve work life until the very end. Often it's the more personal things that go first, and people are highly protective of their employment. So if someone starts to develop employment issues, usually that indicates like an end stage of the disease. So in this case, that didn't develop. She was stopped by the police and failed a field sobriety test, but because they were buddies and knew each other from the courtroom, the police actually gave her a pass on the breathalyzer and drove her home. 2 weeks later, she was admitted to the hospital with intractable vomiting of blood and ending up in the ICU. So I think this illustrates a nice point, which is that often, seeing people struggle with an illness or a problem or a disease, the inclination is to help them, as this police officer probably felt that he was doing. However, without consequences being reinforced, it's often difficult for people to break out of addiction. So you can see that this didn't end up being a good thing for her, because she continued to drink to the point of this vomiting blood ending up in the ICU, which is, the intensive care unit. So she was found, and I switched the gender, which was not meant to happen, but she was found to have bleeding esophageal veins on her assessment, which is when the liver is so cirrhotic and filled with fiber and not functional anymore that you get this backup of blood, and it's one of the big causes of death for alcoholics, and you get these big dilated veins inside your esophagus, and they can rupture and you can bleed out very quickly. So when these were found, she was warned that absolutely any further drinking could be life-threatening. She was offered to go to residential treatment, and she actually had the ability to do so from her job with disability, but she felt that she was had too important of a job, couldn't take the time off, and so chose not to go. 2 weeks later, she relapsed, again developed esophageal bleeding, and because she was living alone, because everyone had become isolated from her, passed away at age 43. So I think these cases really illustrate some of the key themes with addiction as a disease. So no matter what the severity of the addiction or illness, whatever the drug of choice, there's always the potential for recovery. And that recovery can be profound, as we saw in the case of PG, the physician. Again, just to highlight, people who achieve sustainable sobriety and continue with an active recovery program can have a huge impact beneficially on their community. And then if untreated, addiction is a lethal illness like terminal progressive cancer. So I often hear the argument, isn't using drugs or alcohol a choice? And I would say, there's multiple lines of evidence that the disease of addiction is a disease, although there's obviously some element of environmental exposure, just like with many other chronic diseases. And it's true that this disease does not develop if you're never, ever exposed to addictive substances, but sort of the norm of our society is that most people do get exposed to alcohol or other drugs at some point. So addiction is inherited, and it's linked to specific genes. You can find many different ways to pay a lot of money for some genetic testing for alcoholism predilection on the internet. I don't think any of it is really very scientifically valid at this point, but I'm sure at some point that will happen. There's strong evidence, and I'll be showing you some images of the brain changes that come along in response to alcoholism and addiction. You can see very clear changes, very reproducible changes in the brain. And there is evidence also that ongoing treatment is similarly effective in treating addiction as it is in treating other chronic diseases, and we'll go through more about that. Just to highlight the idea of alcoholism being inherited, I broke out some slides about alcoholism as opposed to addiction in general because there's just a lot more research done on it because it was started to be investigated much earlier, although I would point out that a lot of these things I say about alcoholism probably relate to addiction as well of any substance. Studies on children separated from their biological parents, so one of the classic ways we look at whether a disease is inherited, shows that sons of alcoholic biologic fathers are more likely to be alcoholic regardless of whether they're raised by non-alcoholic parents or raised in the alcoholic home, so sort of breaking out the effect of the environment. And interestingly, so it was a much more powerful effect in sons during these landmark studies, but it's probably escalating in women as well. So this is one area where unfortunately it might be bad that women are gaining equality. Twin studies also are a powerful way of looking at the influence of genetics. So looking at fraternal twins who have different genes but are raised in the exact same environment, or identical twins who have the exact same genetic setup and are raised in the same environment, show that there's more concordance or similarity between the rates of addiction for the identical twins as compared to the fraternal twins. So it's thought that the only reason for that is the genetic influence. Based on this and some animal research, the thought is that about 50% of the contribution to alcoholism is actually familial or related to genetics, which is really large effect. So that's larger than the effect of, diabetes on increasing your, like having a diabetic parent as increasing your chance of having diabetes. And I don't think that many people would argue that that's a powerful familial effect as well. There's also a lot of converging lines of evidence that neural dysfunction is a part of addiction, and that as this progressively goes on, that neural dysfunction gets worse. So as we learn more about the brain, there's more and more ways to see this. As a general rule, also the more dopamine that is released by a drug of abuse or a substance of abuse, the more addictive the substance. So this comes up with this dopamine reward hypothesis that you can just look at how much dopamine a drug releases into your brain, and that will be a more addictive drug, and that cuts across a lot of different categories. And then the progressive use causes changes in the architecture of the brain, so it actually reshapes the way that the receptors are embedded and makes it so that there's like a different response to dopamine, so you need more and more of the drug of abuse to be able to trigger the same reinforcing effect. So it becomes this really vicious spiral. So can we think of other chronic diseases that involve the interplay between genes and environment? Does anyone have any that jump to their mind? Eating too much or obesity, absolutely affected by your behavior. Hypertension or high blood pressure, absolutely affected by your behavior and your salt intake and your exercise level. What about other? Sorry? Gambling, yes. And I would submit that that's also a form of addiction. And diabetes, I heard too, and certainly, again, something that you can absolutely have powerful impact on by your behaviors. Cancer, exactly. Like certainly smoking is like one of the absolute biggest risk factors for cancer, and that's absolutely a lifestyle change. So as a society, do we treat other diseases that involve lifestyle choices medically? And I would say yes, So certainly, like, we wouldn't follow someone home, see if they've been eating hamburgers, and then take away all their heart medicine, right, and put them on a list of people who couldn't be admitted to the hospital for coronary catheterization. That would be outrageous. And then same thing with lung cancer. We treat people comprehensively regardless of whether they make the choice to continue smoking. Same thing with diabetes. You can make the choice to, have an ice cream sundae on a daily basis, and we will continue to treat you in an ongoing way in the medical field, which I think is the right thing to do. I thought I had one more, but I didn't. So just to go back to how addiction affects the brain, because there's so much evidence. It's really interesting stuff. So because of the way that addiction hijacks the brain and where it works in the brain, it actually takes control of your reptile brain, or the parietal area, which is like the back of the brain and the same part that's responsible for telling you have to breathe and protect your children and reproduce. And it's that system that gets really hijacked by addiction. And unfortunately, once that pathway starts to develop, there's no way to change it. So there's no negative feedback loop or no way of going back and taking away those changes in your brain. So sort of the more drugs you use, the more that addiction pathway gets stronger. And there's only like that forward momentum. And this goes along with a lot of sort of brain theories of like those neurons that fire together wire together. So if you are constantly strengthening that part of the brain by activating those pathways, it actually gets more powerful, those connections. So what happens is, people don't start out being like, I want to be a heroin addict. That sounds awesome. They'll try like a pain prescription pill. It starts to activate this pathway. And then you, unfortunately, because of the way the dopamine stuff works, you need more and more of the pain pills. They're very expensive now. And then they transition into, doing things they never thought they would because of needing to activate this pathway. And because the way it works in the body, it actually feels like if you don't activate this pathway, you might die. So it's an incredibly powerful brain loop, and it takes an incredible amount of effort and treatment to be able to break that connection. Does anyone have any questions about that? Because I know it's a little bit complicated of an idea. Okay.
Is addiction substance specific?
So
Can I go from alcohol to...
So that's a great question, and it absolutely is. I mean, the phenomenon of addiction is regardless of drug of choice, but there are sort of demographic differences and small, subtle differences, but that underlying drive going through the dopamine pathway is the same for all drugs of choice, and it's easy to transfer from one drug of choice to another. So in general, if you have a history of opioid addiction, you shouldn't, try to cure that by drinking. Yes. What? Yeah.
About 2 years ago, there was a clinic doctor, Cragen, and he's of Irish descent, and the first question he asked people, he said, what ethnic group has the high rate of, in the alcoholism? I just took the Irish out of my mind, and he said, yes, and he said that his father was an alcoholic, in fact, but he lived quite well. His father was a gambler, and he said that the winters in Miami Beach, I guess, down there, he'd go there for high line, what do you call it, racetrack, he'd bet on the horse, and he was pretty lucky. But after a while, he bet on the wrong horses, slow horses, and they started going for beer. But he found that he never, I think he's a moderate drinker, but not to do anything like that, and I wonder if there could be genetic factors because of that.
Yeah, so we had a question about genetic factors related to gambling as an addiction. And certainly I'm sure that there are. Recently there was a big update in the diagnostic manual used by psychiatry from number 4 to number 5, and one of the big changes was that for the first time they included a behavioral process in the definition for addiction, and it was gambling, because there is so much evidence that the behavior of gambling acts just like the use of a variety of drugs of abuse, so that was actually included formally in the definition for addiction.
Many Greeks gamble, poker and this and that. They're not heavy drinkers, but they gamble. My family doesn't. I wonder if that could be an addiction.
Yes, I think gambling absolutely is an addiction. Sir?
Your chart talks about how it's kind of a hardwired thing to be addicted, and that it's very difficult to break free from it. So how do you explain my dad who one day decided, I'm going to quit smoking and drinking?
So that is a great question, and I have a slide that actually addresses that exact point, because I get that question a lot. And I would say the short answer is it's probably, there's a difference between problem use of a substance and being an addict. There are people who don't have that genetic predilection, who do have problems with alcohol and drugs, and they're very easily able to stop. That is probably the majority of people who have problems with drinking. So the majority of DUIs and people who get into trouble with drinking are actually not alcoholics or addicts. It's a specific subset, and we'll talk more about how you make that determination. So yeah, we're going to talk about that too. We're going to go into treatment. So this isn't just going to be, a discussion of the problem, but I really want to highlight like how powerful this solution is as well. So with that, if it's okay, I'm going to move on. Oh, one last question. Yeah, so again, it's like I planted you because we'll kind of go into that some, but it's like the main treatments, one of the huge scientifically based treatments is 12-step recovery, which is probably the biggest group is Alcoholics Anonymous. And there's a lot of debate about why it works. It's absolutely unquestionable that it works. And it's probably by changing your behavior. And as you do different things, you're creating new circuits in your brain. And so, like, bypassing those old behaviors. But there's a lot of controversy about why exactly it works. What's absolutely clear is that it does. And that's a great example. So this is just a picture of where the nucleus accumbens is in the brain, which tends to be one of the centers of addiction. And that's really where the pleasure center is, so all the pleasure pathways kind of go through there. This is some objective images of just showing like what can happen to your brain as you become addicted, so you can see. This is showing both a brain as well as a heart. And you can see with both the healthy brain and the healthy heart, there's like nice, uniform, symmetric activation. And then with the diseased brain and the diseased heart, things look a little moth-eaten and not quite as intense. And that's, just showing that the activation patterns really do change in the brain when you're suffering from the disease of addiction. This is showing the dopamine receptors for a variety of different addictions. So cocaine, meth, alcohol, and heroin, all showing, profound decreases in the amount of activation of the dopamine receptors, which sort of functionally is what drives people to want to use more of their substance of choice. This is like an image of blood flow in a normal brain versus a brain affected by heroin, long-term heroin use, and you can see there's really profound reductions in the amount of blood flow. And then, I think a key thing to point out is that these reductions and changes are not permanent. They go away with a period of abstinence. In some cases, unfortunately, it might not be 100% of a return to normal function. It really depends what the substance is, how long there's been use, and a variety of factors. But there's always some level of improvement with sobriety. This is, again, the same sort of phenomenon with methamphetamine this time. And you can see it's like 14 months of abstinence, things start to look pretty normal again. This is just my daughter, who makes me very happy. She's super fun. And, then just to discuss, to think about, I really think that it's great to have this opportunity because I love to talk about how as a society, how do we really do the best job of treating people with addiction as people with a disease and not marginalizing them and making it more difficult for them to recover. So one really amazing statistic is that there are 22 million people in America who are diagnosable with the disease of addiction, and out of that 22 million people, only 2 million people actually get to go to treatment. So let's think about that. Like if only 10% of the people who had a heart attack or passed out from a diabetic coma were being taken to the hospital and the other 90% were told they didn't have sufficient money to do so, we would be outraged. You know, I think that that would not last long in society. But yet that's like the level of treatment of addiction we have going on at this point. And I think that really reflects, again, that underlying just distaste and stigmatization of addicts that's really lasted for a long time. And again, you know, would you make the argument that you wouldn't want to treat someone for their heart attack because they smoke or eat hamburgers? And I would say that, I mean, first of all, it's just not done. That's not how people are treated in the hospital, and I think most people would agree with that. I think that an interesting thing to review is how we treat as a society impaired physicians, because I think if you're going to look for the gold standard of treating any kind of disease, you want to look at how doctors treat themselves, because it tends to be pretty good. So how do we treat physicians with alcoholism? Very differently from the way most patients are treated. So they go to inpatient rehabilitation for at least 3 months, and most often to one that's abstinence-based and promotes AA attendance. They're monitored for 3 to 5 years and have ongoing random drug testing that's directly tied to their ability to continue working. So there's just like an incredibly potent system for monitoring them, as well as an incredibly strong reward and punishment system for whether they stay abstinent or not. So it's very different from the average treatment episode. And the outcome rates are awesome. 70 to 80% of physicians who suffer with addiction attain successful long-term recovery and return to employment. So that's really different from the non-physician numbers. I'm going to skip this part because I really want to get into the treatment. And I see I might be running out of time soon, but one thing to mention is that, you know, I always hear about detox as being treatment, and I just really want to highlight that just detoxing someone from a substance is not the same as treating their addiction. Almost always we see people relapse immediately if they're only detoxed directly from the substance, and that's because it takes a long time for the changes in the brain to be repaired. So if you're treating someone for 5 to 10 days just to make sure they don't die of withdrawal, that does not give enough time for those changes in the brain to change. That takes more like 14 to 18 months. And this is just showing, again, highlighting the point that the blood flow and the brain changes do actually get better with time and sobriety. So again, to your point, sir, about my aunt, brother, cousin got a DUI and was a horrible drinker and embarrassed me all the time at family functions, and he just stopped. So what's wrong with these addicts? And in short, again, they're probably not meeting the definition of alcoholism and addiction. So the normal response is when you get in trouble or get a DUI or your doctor tells you you better stop drinking or you're going to die, is to stop drinking. And if someone cannot stop, then that's pretty definitively a sign of being an addict. And a reason to think about, like, if your doctor tells you to stop eating broccoli, most people don't have a real problem doing that. And so why is this substance so much different? There's probably some emotional, strong brain component to that reason. There's like a way of identifying addiction we call the 5 C's, and it helps break out people who suffer from this disease versus people who just have sort of exuberant use. One is craving, so that strong desire to use a substance to where it sort of consumes your thoughts. Compulsion, which is, you know, continuing to use the substance despite not wanting to. Loss of control, so saying, you know, I'm not going to drink again, but then somehow finding yourself at the bar the next day. Continued use despite consequences, which we saw with the patient who died of their varices, their esophageal varices. And chronic use, or just continuing to use over time. Again, the majority of people who have problem alcohol use or problem drug use are actually not addicts. That's a specific definition, and it requires a specific diagnosis, and you have to meet specific criteria. So they're not the same thing, and you can't just, see someone who's intoxicated and know that they're an alcoholic necessarily. Most people with drug and alcohol problems can stop on their own. So, there's like a huge continuum of issues with alcohol, and the majority of people who have the issues are in the category of not addicts. The 5 C's can help you determine who has the disease of addiction. This is my other daughter, Cora. She's 7, and she's also makes me happy. I'm going to kind of skip through all this stuff that alcohol does, again, to get to the treatment. I do think this is a good slide to highlight the incredible brain changes that can occur from alcohol use. So you can see with the healthy brain, there's nice full foci of the brain. Everything looks nice and symmetric, and you can see there's a lot of nice neural matter. And then in the alcoholic brain, you can see there's huge spaces where the brain has actually died or atrophied, and there's just sort of fluid filling that in and profound changes in their ability to think. There's a very significant disease called Korsakoff psychosis that comes as a result of chronic alcohol use. Alcohol cirrhosis is also a huge problem. It's not hard to tell which is the healthy liver in this slide. But here we go. I really want to hit home about treatment because there absolutely are treatments for alcoholism and addiction. First, there's medical treatment. So I'm a physician, so I have to put that first. I'm going to also skip through this, but just another sort of slide just showing how potent alcoholism is at affecting people. I'm also going to skip these. But basically, addiction causes a lot of family issues. Here, I will talk about them briefly. Why bother to treat addiction? Because even if addiction is not in our family, it's a huge cause of violent crime that obviously can affect lots of people. It's involved in like 80% of domestic violence and murders of women. It's also an incredibly potent factor towards causing suicide. It's involved in 1/4 of all suicides, and something like 60% of people who commit suicide are intoxicated at the time that they do. It's 120 times more prevalent to commit suicide in the alcoholic population than in the normal population. Not that alcoholics aren't normal, general population. There's family effects, so these are my daughters again. And it's a huge factor in 70% of all cases of child abuse. And adults with substance use disorder, 2.7 times more likely to report that they abuse their children, and 4.2 times more likely to report they're neglectful of their children. So, I mean, just clearly this has a lot of impact on people besides the alcoholics and addicts. So it's something that really has profound effects on society. Also, in utero exposure can cause profound changes that last a lifetime and have a lot of implications for lifelong. Fetal alcohol syndrome being one, but also syndromes related to cocaine, heroin, other drugs of abuse. And then there's a profound effect of increasing the rate of divorce or separation in alcoholics as compared to non-alcoholics. So they seem to be marrying people at the same rate, but then those marriages aren't quite as robust. Now to get to the treatment, so there's a couple of different pharmacological or ways that drugs work in treating addiction. So the first is through agonists. So agonists are similar to the drug, so they're sort of replacing the drug and doing a similar thing, activating the same pathway. So some of those are Suboxone, which you may have heard of, which is a partial opiate agonist. Methadone is another drug that's been around and been used heavily for many years. There's also, nicotine patches for treating nicotine addiction and smoking. Heroin for heroin dependence is actually something that they do in Canada, but we don't do that here. Then there's like the opposite phenomenon, or using something that blocks that receptor as a treatment to help be unable to use that drug anymore. And so the big ones for that are oral naltrexone, which is the opposite of an opiate, and injectable Vivitrol, which is a long-acting form of oral naltrexone, which goes into your body and stays there for a month and blocks the ability to be high on opiates. There's also disulfiram or Antabuse for alcohol dependence, which blocks the ability to process alcohol. So all those are treatments that have been around and have some scientific efficacy. The success rate for most of the medications is 40 to 60% over a 1 to 2 year period, and that is really, really similar to the success rate for treating other chronic illnesses. So our track record for treating diabetes and high blood pressure and coronary artery disease, we're not 100% successful at those things. It's similar to this 40 to 60% rate. Often when patients come off medications, they relapse, and relapse can be associated with death. This is some evidence from 1988 from one of the landmark studies on methadone maintenance, and it's showing that the rate of death drops, the rate of use drops dramatically from 100% to about 30% with use of methadone maintenance over time. And then the rate of people returning to use is that within 10 to 12 months of stopping methadone, 82% of the addicts return to use. As a caveat, these people were not treated with the other lifestyle things that can go along in treatment that we're also about to hit and look at the evidence behind as well. But this is just the medication alone was the only thing studied in this study. Cognitive behavioral therapy is a really robust way of helping to treat addiction, basically with the idea that behavior is due to having a set of false beliefs. So if you change the underlying false beliefs, you can change the behavior. And I'm not a therapist, so I don't have a detailed idea of how this works, but it's sort of like this iceberg with all these erroneous ideas underneath, like often like very low self-esteem, a lot of negative thoughts about self, and then because of all those thoughts, the thought is they're driving the behavior of continuing to drink or use. The other big category of solutions is spiritual, with the big example being Alcoholics Anonymous, which was started in the 1930s and has profoundly affected millions of people. It promotes the idea of spirituality, which is not necessarily the same as religion. Just as a sort of ad hoc definition, religion is for those who are afraid to go to hell, and spirituality is for those who've already been there. There's a lot of other definitions as well, and it's not thought that it's that important what the commitment is necessarily, but the idea is that by having a commitment to something greater than yourself, you're able to bypass some of these pathological behaviors. Another really good example, so I put down formal religion, 12 steps, or Native American sweat lodges. The Marines are another really good example of a way to bypass yourself through a commitment to something else. And that's actually been a way that's been studied to help people sober too. There's a lot of different 12-step programs. You can find like many different anonymous programs if you need something specific to your drug of choice. This is breaking into some of the evidence for AA as a legitimate treatment from a project called Project Match, which was a project done in the VA to try to work out what kind of therapy was most effective at maintaining long-term sobriety. And there was 12-step recovery, motivational, emotional interviewing, and cognitive behavioral therapy. And in this slide, you can see there's a profound effect of the 12-step recovery being the most effective at maintaining sobriety, although it's only about 35% abstinence at 3 months. you can also see this broken out into having no AA at all and attending AA. So this slide is sort of to highlight some of the people who are in the different groups were actually going to AA too. So when they broke those people out and put them in a different group and looked at people who didn't go to AA versus anyone who went to AA, the AA was about 50%, 45 to 50% effective in that case, because some of the people who did the 12-step facilitation didn't actually go to meetings. And then this is, I think, a really powerful slide, because with any medication, one of the huge things you want to look at as indicating that it is effective is if you increase the dose, you increase the effect of treatment. And so this is showing that the more AA meetings you go to, the more effective it is at continuing with sobriety. So in this case, people who went to more than 50 meetings in a 12-month period were about 60% likely to stay sober. So that's, significantly better than 35% and approaching that 70 to 80% we saw with physicians earlier. So these are just some slides highlighting, again, just the idea of drug dependence being an illness. And just to think about the idea that often people who relapse are perceived as hopeless, whereas lots of people with diabetes, develop florid issues with their blood sugar. Lots of people with asthma, don't use their inhalers. Lots of people with high blood pressure don't take their medicine or stay within their goal blood pressure and end up with a lot of side effects, and we don't blame them or punish them for those things. So it's a really different paradigm of being forgiving and treating people versus blaming them essentially for their illness. So if you stopped taking your insulin and wound up having a coma and going into the ICU, your doctor would say, you need to go back on insulin. Let's get you in right away. You could have died. There'd be like teams of people surrounding you. If you stop your Suboxone and wind up in the ICU, your doctor would say, you're an addict, you're hopeless. And often just sort of discharge you back to the street without any re-engagement strategy. So it's unfortunate that that's the case, and I think that we're moving towards a different paradigm, but it's going to take, I think, a lot of work. There's also evidence that opioid maintenance therapy decreases HIV rates, decreases incarceration, decreases drug use, and decreases mortality. But there is not really evidence that you can stay sober, again, through detoxification alone. There's got to be some kind of ongoing treatment paradigm, and that can be, AA, spirituality, or some sort of medication, but there's got to be some commitment to ongoing treatment, just like with other chronic illnesses. So I would just say that addiction should be classified just like all these other diseases, which most of you identified before, and treated appropriately like the disease that it is. So thank you so much for all of your attention. And at this point, we have a few minutes to have more questions. Yes, sir.
Who's going to pay for this?
Oh, well, so I would say who pays for most medical treatment? There actually have been laws passed recently that stretch the definition of chronic disease to include ongoing treatment for addiction, so there probably will be big changes coming.
What means if we don't do it?
Yeah, exactly. Yes, sir.
Is there any evidence that younger physicians are more receptive to looking at this as a disease than older physicians? There's no breakdown on that?
So I did a project in my residency, and I actually found the exact opposite, which was really interesting. So we did an objective survey of the various levels of physicians at our hospital, and it looked like the people with the most bias were actually the youngest physicians, probably because as people stay in their career, they come into contact with people in chronic long-term recovery and see how much they're benefiting and how things can normalize for them, whereas when you're a resident in the hospital, you're seeing people coming in and out, and it really reinforces stigma to see patients going in and out of the ER without knowing that there's this whole other cohort of people who are in chronic stable recovery. So it's really interesting. Oh, yeah, sorry. The question was, is there a difference in younger physicians and the level of stigma versus older physicians? Yes, sir.
If I understood you correctly, there's really two types there's clinical addiction, and then there's, for lack of a better word, the bad habit. Are those binary states, or is there degrees between those?
Absolutely not binary. And you can absolutely, be a problem drinker and develop addiction. That's where that's a continuum. So the question is it binary to be in the category of problem drinker or alcoholic addict? And, it's not that simple. I think, you have a certain amount of genetic predilection and a certain amount of environmental exposure, and at some point you cross that barrier. But it absolutely can happen at age 65, 75, with enough exposure to substances. Yes?
Can a parent put a child into one of these programs if they're on drugs?
The question, can a parent put a child into one of these programs if they're on drugs? And the answer is they can try. It certainly works the best if that person has a desire to get sober on their own, but it's certainly also effective, as you could see with the sort of physician numbers, just to be held to doing that. That if there's clear consequences and it's kind of a thorny issue. There's a lot of people who feel like you need to really be internally committed to getting sober, but there's evidence also that if there's a strong framework around you, your parents set strong boundaries, there can be pretty good outcomes as well.
I have a stepbrother, and his son was on heroin and other different drugs, and they didn't do anything about it. And now he is in a nursing home, and he has no use of his brain or speech or anything. And he's only 31 years old. And I was just wondering, if they would have got him help, maybe they could have helped him that way.
Yeah, maybe, but maybe not.
Yeah.
So it's that's a really sad story, though. Yes.
Can you speak to addiction as a family disease? I know you said you're not a therapist, but the idea of codependency and so forth, enabling.
Yeah, so absolutely. So this question was speaking to addiction as a family disease, and that's a great question. It's certainly something that we see, at Hazelden, there's certainly programs to help the family recover as well. The idea is that because of the profound pathology in the family from the person acting out in their addiction, it causes a lot of changes in the structure of the people who care for them, because they're trying to go out of their way to help these people who they love. And so there can be really pathologic things that develop in the family members also, and that can have profound impacts on children and, sort of echo through generations. So there's a lot of evidence for different behavior in children of alcoholics and spouses of alcoholics, and it absolutely is something that affects a lot more people than just the alcoholic themselves.
Is treatment more likely to be effective in a younger person, say 35 than 65?
So the question is treatment more likely to be effective in a younger person at age 35 than 65? And so I would say it really depends, because there are such different profound effects from the length of use. So a 65-year-old who had just picked up would probably have a pretty effective way of recovering. If they had been drinking since 15, they might have such profound effects on their brain that there's not a lot to be done. However, actually probably being more mature with more life skills of being able to like hold down a job and be in a merit, like having those skills can give you skills that can be applicable to recovery. So it's really variable. So it's not quite that easy. Yes, sir.
As a physician, are you seeing more literature out there for physicians to be a little more reluctant to prescribe opiates?
There's a huge movement in the United States to limit access. Oh, the question was, is there a movement to limit access to opiates and have physicians be more reluctant to prescribe them? And there absolutely is. An unfortunate side effect of that is probably the heroin epidemic, which has been sort of directly related to the reduction in access to pills. And, obviously, we need to be careful about who we prescribe pain medications to, but certainly no one foresaw that this would really cause a lot of people to move into abusing heroin at higher rates, and it's led to probably a lot of overdose deaths. Yes?
Could you comment, just, as I remember, there's like a treatment that private insurance is typically paid 28 to 30 days. Is that still relevant, or?
Yeah, so
We don't do that with other chronic diseases, to my knowledge.
yeah, so the question was about insurance sort of limiting treatment to 28 to 30 days, and that's like a whole policy topic. I mean, certainly like a lot of the reason that treatment went to 28 days wasn't because it was scientifically proven to be effective. It's much more effective the longer. It's very profoundly more effective if you have longer treatment periods, but insurance basically said we'll only pay for this amount, and so a lot of places cut down to that because it's incredibly expensive to pay for out of pocket. So I would say that there's nothing scientific about 28 days. It was sort of decided. Yes?
Comorbidity between depression, anxiety, stress, and dependency. Is any cause and effect, people are dependent, addicted first, and then they become depressed, anxious, and have more stress, or do they have depression, anxiety, stress, and then they use the alcohol to...
Yeah, so a really good question, a question about the comorbidity between addiction and depression and other mental illnesses, because certainly people with addiction have a higher proportion of depression. People with depression have a higher proportion of addiction, and a question about like whether one is etiologically causing the other. It really depends patient by patient. I mean, the thing is, a lot of the substances of abuse are profound depressants on the brain, so you can give someone, anyone almost, enough heroin to cause them to be depressed because it is actually a depressant. You can also have the phenomenon of people who are more depressed at baseline being more likely to pick up drugs and alcohol as a potential solution to their depression. So it can really... It's a really vicious cycle, and those things can both reinforce. Usually the best way to work it out is once someone gets sober, if their depression goes away within 1 to 3 months, then we think that it was probably a substance-induced depression.
Does any of your work address like the progressiveness of the disease, whether they're using or not?
Does any of the work address the progressiveness of the disease? You mean helping to stop people from using? Is that the question?
Maybe more related to, where they pick up where they left off, whether it be 10 years since they used or if they were in sobriety and then relapse.
Yeah, so a question about whether when people relapse in addiction from a long period of sobriety, if they tend to be at that same level of progression, and they actually do. So if you've had a period of profound addiction, like get into a stable recovery for 10 to 20 years, pick up another substance and get addicted to that, you can develop rapidly just as severe of issues, probably because of what we discussed with those brain pathways, because they're sort of right there waiting to be reactivated. They haven't gone away. They just haven't been activated in a while. So if you use something else that starts to access those, you'll become addicted much faster than someone who's never had the experience of being addicted. Does that answer your question? Okay. Sir?
Are there support structures, you have mentioned AA, are there support structures for family members, society similar to Alcoholics Anonymous?
Great question. So the question was, is there a support structure for family members similar to Alcoholics Anonymous to help get them help? And there absolutely is. So there's a variety of those too. There's Al-Anon, which is the essentially AA for family members of alcoholics. There's also like Nar-Anon and a variety of different groups aimed at supporting family members of people with different substances. And then there's also like adult children of alcoholics. There's lots of different support groups available for family members as well. Yeah, any other questions? Yes, sir.
Methamphetamine, they say that it worsens some of the other drugs because does it do physical damage like I've read?
The question was that methamphetamine can worsen some of the effects of other drugs, and does it do physical damage? And absolutely it does damage. Absolutely, you know, a variety of different combinations of drugs augment each other in a way that you can't predict clinically, because instead of, you know, they're not additive, they're multiplicative, and unfortunately, you know, using two drugs together can be very unpredictable. So we don't recommend that. And I wouldn't say there's anything particularly horrible about methamphetamine, except it is profoundly affecting to the brain. So you can have long-term hallucinations as a result.
I'll tell you what I encountered in Korea on the front line. We weren't supposed to have alcohol at all. But this man he had an alcohol craving, and he had some hair oil, which his had a little bit of alcohol, and he drank that.
Oh, wow.
I mean, he didn't. I'm surprised he didn't die, but he actually drank that to try to get some alcohol.
Yeah, so, and we'll hear, you know, so a story about drinking, I'm sorry, was it hair dye? To get something that had alcohol in it that no one should ever drink, which is obviously something, you know, we see with like people drink rubbing alcohol, people drink antifreeze, you know, that's a common phenomenon, unfortunately. Yes, people die from doing that.
How does smoking fall into this whole equation?
Good question. So smoking is an incredibly, so the question was, how does smoking fall into this equation? Smoking is an incredibly potent addictive substance. It's actually, if you look at relative addictiveness, close to the level of heroin. IV heroin and nicotine are the two by far most addictive substances that there are. So a lot of the brain changes that come from addiction in general are also profoundly present just from smoking too. Although we don't typically think of that as the same thing, and it's treated a little bit differently. We know also that people in recovery from other substances are more likely to relapse if they continue to smoke, because it acts on that same pathway in the brain and kind of tickles those dopamine receptors. Any other questions? Well, thank you so much for all your attention.
And Dr. Brunner, would you draw our winner for tonight?
Oh, thanks.
Jerry and Pat Harabi. Congratulations. Thank you all so much for coming. We hope to see you back next week.